everyone. A warm welcome to our today's webinar, which is on PPF, Progressive Pulmonary Fibrosis, the best approach. We know this term has newly been coined, and it's something which is extremely interesting and also quite challenging because we have to correctly know how to treat this condition, when to treat this condition, and with what to treat this condition. And we are really lucky that we have the best, most accomplished, most distinguished, and most learned panel today who is going to tell us everything about it. Our faculty is super brilliant. I would like to start introducing today our moderator, none other than the Dr. Kumar Doshi, who requires absolutely no introduction. He is an excellent pulmonologist, a brilliant academician, and most importantly, a very, very dear friend of mine. We've done our medicine together. I was Doshi, he was also Doshi. I was ahead of him. All his papers he's copied from me and he's done so well. And for that, he always remains grateful to me. But surprisingly, he always did better than me, though he always copied from me. Maybe handwriting was better, we don't know. Jokes apart, a brilliant pulmonologist who's extremely talented, a great singer, a great dancer. He is a marathoner. We look at him and we feel breathless. And so many more things to really talk about. But with this brief introduction, I'd like to invite Dr. Kumar. So Kumar, over to you. Thank you.
Thank you, Amita, for always being in front of me. Today's symposia's webinar, I really thank the ICS, Dr. Sudeep Salvi, Dr. Amita Nene, Dr. Rajadhar to having taken this initiative. If I'm not mistaken, this is 28th or the 29th webinar which these guys are organizing, and always having 1,000+ logins. It just shows the determination, dedication of the organizers and the attendees' desperation to learn. In that same philosophy to continue learning and giving the right points or practice points such that we make minimum errors and give the maximum benefit to our patients, we have brought to you today a kind of contentious topic, a topic where names have been changing every now and then. Right through the ages, interstitial lung diseases have been called through a variety of names. This is the first time that we have some terminology which is meaningful. Meaningful in the sense it directs us towards a therapy. Giving you a diagnosis of, say, a squamous cell carcinoma doesn't really tell me what treatment am I giving. If I tell you a squamous cell carcinoma stage 3A, suddenly everything opens up. Okay, this is to be done, this is not to be done. Similarly, when we give this terminology of progressive pulmonary fibrosis, PPF, everything becomes crystal clear as to what we are supposed to do. And this is what we are going to discuss today as to what is PPF, what constitutes PPF, what are the therapeutics. This all starts with a presentation by Dr. Nagarjuna Maturu from the Yashoda Hospitals in Hyderabad. And when I was going through his CV, I was really astonished to see what he has done. He's been doing the largest number of EBUS, largest number of cryobiopsies, largest number of bronchial thermoplasties, 70 articles in national and international journals, 11 chapters in various textbooks. In just 11 years of experience. Amazing job, Nagarjuna. And I'm really looking forward to Nagarjuna's presentation on this very contentious topic of PPF. And then we will go start off with a panel discussion. Over to you, Nagarjuna, and see you on the other side of your talk.
Thank you so much, sir, for the kind introduction. And before I start, I should thank Team ICS and Amita Madam especially for choosing this topic and choosing me for this topic. So ILD has always been one of my key areas of interest. Hope the slides are visible and I'm audible.
Yes.
So in the next 20 to 25 minutes, so what I would try to do is to give the people who have logged in an understanding of the term PPF and why we diagnose, how we diagnose, and how to treat. So this is the whole objective. Though I have given the subtitle as the current understandings, I will also touch upon the current controversies. So that is the intent. So before I start, I will put two slides. These are the two landmark articles. So anybody who's interested to learn about PPF should read this article published in 2022 by Raghu et al. This gives us the current defining criteria for PPF, progressive pulmonary fibrosis. The second article is this by Dr. Sujit Rajan and team global experts. This is a consensus based recommendation. Very happy to see a lot of Indian names in this international guideline document. Not a guideline, it's a consensus statement, but nevertheless, it gives a lot of concepts. So these two papers are a must read for everybody who want to learn about PPF. Now, before we go into PPF per se, we should understand that there are several terms which have been proposed, as rightly Dr. Kumar sir has said, a lot of terms which are used. So one is fibrotic ILD. Then there is something called as progressively fibrotic ILD or PF-ILD. Then came the term progressive pulmonary fibrosis or PPF. So what are the differences between them? So first we will start with what we call as a fibrotic ILD. As the name says, any ILD where there is evidence of fibrosis would be called as a fibrotic ILD. So how do we diagnose fibrosis? Logically, it is either by HRCT or on biopsy. But for diagnosing some ILD to be fibrotic ILD, it is usually the HRCT criteria which are taken. Because biopsy is not done in many cases of ILD, it is done only in a very small subset. So for all likelihood possibility, it is the HRCT definition which is followed. So what are the HRCT features of fibrosis? This is the first thing which we should understand. So what are the HRCT features? The three things which are very important are honeycombing, traction bronchiectasis or broncholectasis, and reticulations. These are the three things which we have to identify on CT, and if they are there, we would tend to call this ILD as a fibrotic ILD. And the thing which we also have to understand is that if you do biopsy, there may be several cases where there is only ground glass opacity and it can have some pathological fibrosis. So it is for all practical purposes, the HRCT definition which is used for defining fibrotic ILD. The blue box is very important, that not every fibrotic ILD progress. So only 20 to 40% of the fibrotic ILDs progress despite therapy. This is something which is very important. When I talk about PPF, so not every fibrotic ILD is a progressively pulmonary fibrosis. So very briefly about the radiological criteria, first thing is honeycombing. This is the pathological hallmark of UIP. So how is it defined? It's a subpleural, lower lung predominant, layers of cysts. So these cysts usually have a sharing wall. They're usually similar in diameter, 3 to 10 millimeters. Earlier, it is said that it has to be multi-layered, but the current definition says even one layer of cyst can qualify to be a honeycombing. So as the disease progresses, the number of layers increase, the number of cysts increase. So this is honeycombing. The picture which is given is from the IPF guidelines in 2022. So this is a very common finding which we see almost on a day-to-day practice. That is honeycombing. Again, we should not confuse it with emphysema. Emphysema is usually upper lobe predominant, larger cysts, thinner walls, and usually one layer only. So this is the difference between paraseptal emphysema and honeycombing. The second radiological hallmark of fibrosis is presence of traction bronchiectasis or traction broncholectasis. So basically, you don't find this dilated bronchi in the peripheries. So if you find the dilated bronchioles in between the areas of reticulation or GGOs, it is called as a traction bronchiectasis. So this is a very important hallmark of fibrotic NSIP, I would say. The third radiological hallmark is the reticulations. So reticulations are nothing but thickening of the intra or interlobular septa. They usually seen as fine lines. So this also is a feature of radiological feature of honeycomb of fibrosis. It can be further classified as being fine reticulation or coarse reticulation. So if you have to be very, very clear, the presence of honeycombing, traction bronchiectasis or broncholectasia are the most definitive radiological features of fibrosis. Reticulations also point towards fibrosis. ground glassing, sometimes if it is in between the areas of traction bronchiectasis, can signify fibrosis. So all GGOs is not necessarily inflammation. That is something which you have to understand. Now, this is one slide about which all ILDs can have fibrotic phenotype. That is not progressively fibrosing, FILD. So this is the same group as what we'll have PPF also, which I'll be talking. So idiopathic ILDs, UIP is the pathological, radiological hallmark of fibrotic ILD, but in the other IIPs, NSIP is the most common associated with fibrosis. Then comes COP. And in the non-idiopathic ILDs, CTD ILDs, HP, sarcoid, and pneumoconiosis. These are the four groups which have a fibrotic phenotype in them. Now that is about diagnosing fibrosis per se. But the whole topic of discussion today is progressive pulmonary fibrosis. So how is this different from fibrosis? As the name says, progressively fibrosing ILDs means they are a fibrosing ILD, but they progress over time. So what do you mean by progression? You look at three things. You look at symptoms, you look at physiology, that is the spirometry or DLCO, and you look at the radiology. So these three things progress: the symptoms, the physiology, and the radiology. And because of this, there is a poor quality of life, and which leads to mortality. So earlier, the PPF was called as PFILD. So PFILD was the original term used when the inbuilt study on nintedanib was done. But now this term has been replaced to progressively pulmonary fibrosis. So basically PFILD and PPF represent the same group of diseases, but the current accepted term is PPF. So this thing just explains the whole thing. So of all the ILDs, that is a blue circle, the fibrotic ILDs are the yellow circle. So that constitutes maybe roughly around 40%. And of all the fibrotic ILDs, a subset of them only progress. That is again 20 to 40% of the fibrotic ILDs progress. That is the red circle. So this is again very important that all fibrotic ILDs need not progress. So once you give correct therapy, they may not progress. So again, now coming to criteria. So what is the diagnostic criteria for PPF, progressive pulmonary fibrosis? If you look at the studies which have been done, each study has used different criteria, different cutoff. So the inbuilt study is for nintedanib, the UILD study and relief are for pirfenidone, and the COTIN study is also for nintedanib. So if you see the cutoffs, they're very, very confusing. There's a lot of gray zones, a lot of variations. But what we have to remember is this criteria, which has been proposed in 2022 by Raghu et al. So this is a group of experts who sat together and put forward the criteria for sake of uniformity. So this we will spend 1 minute because this is very important. So what is PPF? Is in a patient of ILD. So obviously he should have ILD of an etiology other than IPF. So IPF is ruled out because IPF is a completely different physiology, and it is by definition fibrotic, by definition progressive. So IPF is also PPF, but we don't consider it, club it with the other group of diseases. So who has radiological evidence of fibrosis? So it is ILD. It has fibrosis. That is, it is a fibrotic ILD, but it is not IPF. Then you should have two of the three criteria: worsening symptoms, worsening physiology, or worsening radiology. So if you have any two of the three, symptom plus physiology, symptom plus radiology, or physiology plus radiology, if there is worsening on these two domains, it can be called as a PPF. Okay, so just to repeat, it has to be a fibrotic ILD other than IPF, and there should be worsening on two of the three domains, symptoms, physiological or radiological. Now, each of these we will discuss in detail. So, when we talk about symptoms, again, we have to understand that this worsening of symptoms should be because of ILD progression and not be because of a concomitant cardiac disease, concomitant pulmonary hypertension, or something else. So that is something which as a clinician, we have to take a decision. Second thing, when you talk about symptoms, is there are no cutoffs as to what to say as a worsening. So you don't grade the symptoms and then say that this much percentage is considered significant. So this is a gray zone. Now coming to which of these is the correct criteria. So the PPF guideline the PPF inbuilt relief, so on and so forth, if we put in the patients, what we understand is that every criteria will identify a different subset of people. This is something which is very important, and only a small subset of them meet all the 4 criteria, which means that there is still some uncertainty as to what is the correct criteria to be used. But for time being, I would say that this is the one which we have to follow. Now we will discuss about each one of them. As I have said, for symptoms, it is a subjective grading. There is no objective grading. Now coming to physiology, that is the next domain. So now again, we have to understand the terms here. Absolute decline versus relative decline. This I will tell in the next slide. What is the difference between these two? In the current criteria, it is absolute decline. Then what percentage is significant? 5%, 10% or more? And should we use FEC? Should we use DLCO or should we use both? And what is the time frame? 6 months, 12 months or 24 months? So these are all the things which are variable. So now coming to absolute decline versus relative decline. So this is a very good example. For example, if a person starts with an 85% FEC, to call it a 5% absolute decline, which is the criteria, if the FEC has to become 80%. So that is 3.4 to 3.2 liters. But what is relative decline is baseline minus final divided by baseline. So which is, if it is 50%, even a 2.5% decrease would qualify for a 5% relative decline. Whereas absolute decline will be if it has to come down to 45%. So which means that as the FEC falls, the difference between absolute decline and relative decline is more. So this is the smaller nuances, but the current guidelines say that a 5% absolute decline in FEC or a 10% absolute decline in DLCO corresponds to a significant physiological decline. This is what we have to understand. So how do we calculate absolute decline is just baseline minus final percentage. Now, there are a lot of studies which have looked at what criteria actually predicts death. So the whole intent of all these criteria is to prognosticate people and to take therapeutic decisions. So this study, though it might look little complex, what they have shown is that all of these criteria, 10% relative decline, 5% absolute decline, 10% absolute decline, if you see the p-values here, large cohorts of US and UK, all of them are correlating with the prognosis and mortality. The best correlate is actually with the 10% relative FEC decline. But the guidelines currently recommend 5% absolute FEC decline. Now, is FEC better or DLCO better? The guidelines say either 5% FEC or 10% DLCO. But there is a word of caution if you use DLCO, because for DLCO, the techniques are different. So many centers will have different ways to do DLCO technique. There is a lot of inter-individual variability, and also DLCO can be affected by several other factors other than fibrosis. So when you're using DLCO as the standalone criteria in physiology, you should make sure that there is no other reason for fall in DLCO. So that is about the physiology part. Symptoms, physiology. Now radiological worsening. How do you define a radiological progression on a HRCT? This again is subjective. So now there are two options. One which is recommended is a subjective assessment of scans, which means on your packs, you open the old one and the new one, then scroll down simultaneously, and at same anatomical levels, you compare. For example, at the level of carina, at the level of bifurcation of the right main or left main, at the level of aortic arch. So you take an anatomical landmark and then compare the parenchyma at each level and try to see whether there is increase in features of fibrosis. That is what is currently done. But I would say there is a lot of subjectivity in defining radiological progression. Now I'll go back to the slide where the definition was there. So how do we define radiological progression? So if you remember what I have said about defining fibrosis on HRCT, any increase in traction bronchiectasis or bronchiectasis, any increase in fine reticulation, any increase in coarse reticulation, any increase in honeycombing or volume loss are all features of progression. Also, if there is new GGO, ground glass opacity, but in the area where there is traction bronchiectasis, this GGO may actually represent fibrosis and not inflammation. So any of the features of fibrosis, if they're progressing, it is called as a radiological progression, but you don't uh, give a percentage or you'd actually quantify it. It is more of a subjective assessment. So to overcome the subjectivity, now we have AI-based softwares. I'll just touch upon them, but the guidelines do not still recommend this AI-based software. One of which is there available for us in India is the caliper, the lung texture analysis. So what does this do? Is it divides into volumes of interest, and each area voxel, it will give a color. So green is normal, yellow is GGO, orange is reticular, honeycombing, and so on and so forth. So one example, this is not our case. So for example, index scan in 2007, lung function FE1 was 65%. There was 13% GGO, 6% reticular. After 6 months, the lung function did not decline. CT was done. The radiologist felt there was no worsening, subjective. But objectively, what did the computers show? That the ground glassing increased to 32%. So, but again, after another 1 year, the lung function fell down. The radiologist felt there was worsening. And this time, there was increase in GGO to 48%. So in this case, AI could pick up worsening earlier than a radiologist interpretation of the HRCTs. So this could be a game changer in the future, provided we have more robust data. Some centers in India are already using this software. I think Dr. Isaac also can comment later in the discussion. So a couple of cases where we had used this software also, we could objectively document increase in the ground glassing or reticulation. The same patient, 2 times scan was done. If you can see, the green one is the ground glass, orange is the reticular. We can see in the third scan, there is the second scan, there is significant increase in the extent of GGOs or reticulation. So that is about AI-based radiological scoring. But I would again say that this is not yet recommended in any of the guidelines. This is more for information. Now, another question which we have to answer is, how often do we need to redo these tests? The current thing which we follow and which also has been recommended is for lung function, that is PFT DLCO, we do every 3 to 4 months in the first 1 year, because we don't know how the ILDs are progressing. And after 1 year, we probably decrease it to every 6 months or so. For HRCT, it is annually or once in 2 years, unless there is a clinical indication to do earlier. This is what is the general consensus on how often we need to redo these tests. Now, what is the time frame to define progression? So in the current guidelines, it is 1 year. So you have to wait for 1 year to define PPF. But there are certain studies which have used a 6 months criteria and certain studies which have used a 2-year criteria. If you look at the original PFILD nintedanib study, it used a 2 years criteria. Now, there is one very recent article published a couple of months ago, which compared the 6 months, 1 year, and 2 years. It's not 5 years actually, 6 months, 1 year, and 2 year criteria. And what they've shown that the 1 year and 2 year criteria were more accurately predicting the mortality or lung function decline as compared to the 6 months criteria. So that is about the criteria. So just to go back, I think this is something which we have to understand again. This is the thing. So in a case of fibrotic ILD, which is not IPF, PPF is defined as worsening of 2 domains in the last 1 year. That is symptoms, physiology, or radiology. And I will talk about one last thing again before I go. Is this should happen despite optimal therapy. Now, that is about defining progressive pulmonary fibrosis or PFILD. Now, there is some predictors of PPF. So can we, if we diagnose a person to have fibrotic ILD, can we predict whether this person is likely to develop progressive pulmonary fibrosis? Again, we don't have data for all the subgroups of ILDs, but in general, if the person has UIP pattern as compared to NSIP, it is more likely to become a PPF. Similarly, a lower lung function or an earlier decline in lung function is a predictor of further decline. Similarly, for fibrotic HP, if you can identify the antigen, then it's a good prognosis. Similarly, for rheumatoid arthritis, higher levels of CCP are indicative of a likelihood of progression. So for each of these diseases, you have studies which have looked at what are the predictors of progression. This is there in the article by Dr. Sujit Rajan et al. You can go through this. It is open access. Now we have finished the definition of PPF. Now coming to the last two parts, it is what are the diseases causing PPF. So in ILDs other than IPF, this is a beautiful picture from Dr. Raghu et al.'s article. So the white boxes are the diseases and the blue boxes are the percentage of people who can develop PPF. If you can see in the IIPs, NSIP is the one which has a significant chance of fibrosis, followed by PPFE. PPFE per se is not very common, and unclassifiable ILDs. If you're not able to classify the type, then it is more likely to be fibrosing. Then autoimmune ILDs constitute a significant chunk of PPFs. RA, SSC, scleroderma are the commonest causes of PPFs. Fibrotic HP again is a significant burden in India. Occupational ILDs are a significant cohort, and fibrotic sarcoid to a smaller extent. And post-infectious ILD, it's again a gray zone, but then post-infectious ILD also has been included for sake of completion. The same thing in the article by Dr. Sujit Rajan, this is how they have put it. IPF is always PPF. IPF by definition is progressively fibrosing. That is the central box. And if you look at the other groups, fibrotic HP is there, CTD ILDs are there, undifferentiated ILDs are there, sarcoidosis to a smaller subset, idiopathic NSIP to a significant subset. So these are all the ILDs which can have a PPF phenotype. Now in Indian surveys and global surveys, the right one is the Indian doctors and the left one is the global doctors. So if they ask in their clinical practice what percentage develop PPF, so the answer generally is around 20 to 40%. This is what most of us say. In India, also the same thing. 35% of the respondents felt that 15 to 30% of their patients developed PPF. Now the patient journey, this is also very, very good slide from a poster. So from the symptoms to diagnosis of ILD, it generally takes 1 year. Then to develop PF-ILD, another 1 to 1.5 years. By the time the clinician diagnoses that it is PPF, another 1 year. So already 3 years is gone. And then after another 3 to 4 years, usually death happens. So this is a very good flow chart of how to diagnose PPF. So first thing is you diagnose somebody to have a fibrotic ILD, then you should identify the cause. That is very, very important. You should identify, you should not leave it as a fibrotic ILD because you have to initiate therapy. This is very, very important. So you have to first start the disease-specific therapy. If the disease stabilizes, does not progress, we are happy. If the disease progresses despite therapy, then that is actually called as PPF. That is where you have to intervene. So if the initial diagnosis is of an ILD which does not require therapy, then you monitor. If it is stable, it's okay. If it is progresses, again you treat. And if despite treatment it is progressing, it is called as PPF despite therapy. So why do we need all these definitions of PPF? So basically for two reasons. One, for its prognostic significance. Second is for therapeutic significance. So prognostic significance is that it predicts mortality. So this is one recent paper published in this year from Korea, 220 patients retrospective study. So 40% of these ILD patients had developed a PPF phenotype. And when then they looked at the survival, so if you can see this Kaplan-Meier survival curves, the PPF group had a significantly low survival as compared to the group which didn't progress. So if a person develops a PPF phenotype, which means that he is likely to have a poorer prognosis in general. Second importance of PPF is its therapeutic significance. That is what in the last few slides I'll be talking about. So what is the management difference when you diagnose somebody to have PPF? Here again is very important. So PPF again, if you look at the literal meaning of PPF, if it is progressing, it is called PPF. But is it despite therapy or is it at diagnosis? Many times what happens is when you diagnose somebody to have ILD, already he would have progressed. So you're diagnosing at a stage when already it has progressed. So that, okay, it can qualify for PPF, but that is not what we want. So what we want to identify is this box of PPF where the disease is progressing despite initial optimal therapy. That is, if you diagnose a CTD ILD, you have to put him on immunosuppression. And despite immunosuppression, the disease progressed. That is called as PPF despite therapy. And that is where the role of antifibrotics come in. Okay. So the role of antifibrotics is when you diagnose PPF despite therapy, you have strong data for nintedanib and relatively weak data for pirfenidone. It is to be important that this is an addition to the immunosuppression. It is not standalone. Now, I will not go into the studies, but I think this will be discussed in the discussion also. The most important study, the landmark study, is the inbuilt study of nintedanib in progressively fibrosic lung diseases. When this was published, the term PPF was not there. It was PFILD. That's what is written here. So 663 patients randomized to nintedanib or placebo. Nintedanib was added to the background therapy. And if you can see the difference in FVC, when we give nintedanib, the fall in FVC is lesser. If you don't give nintedanib, the fall in FVC is more. And what groups? The same groups which we are talking about. 25% HP, 25% autoimmune disease, 25% idiopathic, 20% unclassifiable and others. So this is what the gross distribution of PPFs would also look like. And subgroup analysis was done. And each of these subgroups also nintedanib works. So it works across the etiology. Once it develops a progressively pulmonary fibrosis phenotype, we can add nintedanib irrespective of the basic diagnosis. Now, pirfenidone, you have two studies, the UILD study and the relief study. Individually, they could not show much benefit, but the meta-analysis which has been published again by Raghu et al. Has shown that when we club these two studies, pirfenidone seemed to be better than placebo in reducing the FVC decline, DLC decline, and 6-minute walk distance decline. So now the only thing which I would like to say is that when can we start antifibrotics at the beginning itself? So one is IPF. You have to start antifibrotics at diagnosis. Second is scleroderma fibrotic ILD. This is based upon the Census trial where you can start antifibrotics in scleroderma fibrotic ILD even before you prove PPF. The third group, this is more of an expert consensus thing, is if you have RA with UIP ILD, you may be okay in starting antifibrotics at the beginning. But barring these 2 to 3 groups, you do not start antifibrotics just because there is fibrosis. You have to start the therapy. If the fibrosis progresses despite therapy, that is when you start the antifibrotic. Now, pirfenidone versus nintedanib, again, this has been a point of debate from the time they have been approved in IPF. Both work equally well, I would say. But if the person is having an outdoor hobby, because pirfenidone can cause photosensitivity, nintedanib may be a better option. If the person cannot tolerate nintedanib because of diarrhea, you can give pirfenidone. Because of its ability to cause thrombosis or bleeding, when a person is on anticoagulation therapy or having CAD, pirfenidone may be a better option. But these are all not an absolute things to choose one over the other. Now, the other question which we have to understand is, if at all we diagnose PPF in a patient of a fibrotic ILD non-IPF, so what do we do? Okay, we add antifibrotic to the immunosuppression. But what do we do with the immunosuppression? Do we continue the same? Do we withdraw the immunosuppression? Or do we increase the immunosuppression? This is something which we do not have answer yet. So also I would like to say that PPF, we should not forget that drugs is not the only thing. Rehabilitation has to be a part. Oxygen, if required, has to be given. If he fulfills the criteria for transplantation, he should be referred for transplantation, and so on and so forth. At this point of time, we have evidence only for nintedanib and pirfenidone. But if you look at the number of studies ongoing, a lot of studies with newer molecules also, so which I will not be anyway be talking much about. So to conclude my talk, the most important thing is identify fibrosis. All fibrotic ILDs are not progressively fibrosing ILDs, and it is important to diagnose the etiology. Nowadays, what is happening is the moment you diagnose somebody as fibrotic ILD, just they're dumping up antifibrotics and not even trying to get the etiology. So the first step is get the etiology correct, treat the disease, and then you assess for PPF. So PPF can be diagnosed if there is progression on two domains despite therapy for 1 year. And in this group, there is role of adding antifibrotics. I think with this, I will end my talk, sir. And I think we'll be open for any questions and for the discussion.
We will take all the questions which have been pouring in at the end. I must congratulate you, Nagarjuna. It was crisp, it was precise, and to be very honest, I'm sure it must have answered too many questions. I'm just going to now dig deep into this and try to get more questions and more clarifications, and we can have a more wholesome discussion on the whole thing. With this, I invite all the panelists to begin with our teacher, Dr. J.C. Suri. He has been the stalwart, I would say, a big name in respiratory medicine. He has established the first state-of-art sleep lab in India. He was also started the DM program in pulmonary critical care at VMMC and Safdarjung, the second center in India. He was also the vice principal academic of VMMC. He was instrumental in developing the course curriculum and exam ordinances for the MBBS students as GGS IP University. A thorough, deep academician. I have been really grateful that he agreed to be a part of our panel discussion today, and we are very blessed to have him around. Our second panelist is Dr. Barney. He is a professor of pulmonary medicine from CMC Vellore. His areas of interests are, of course, ILDs, pH, lung transplant, CPET, and biostatistics. Has 44 index publications. Was awarded the Young Scientist Award at NAPCON in 2009 and the Best SAS Trainer Award in UK in 2014. Next, we have a dear friend from Bombay, Dr. Radhika Banka. Her CV is too large. I must only say that much. She has 55 conference presentations, 29 publications, 4 book chapters, 25 journal articles. She has been the editor reviewer of PLOS ONE respiratory case reports, cancer investigation, and translational lung cancer research. She was an invited faculty of ERS 2023, invited faculty at ERS PG courses for pleural diseases October 21, 22, and November 22, and also invited as a faculty for BTS thoracic ultrasound short course in Oxford in March 2020. Welcome, Radhika. And finally, we have our young gun, Dr. Aparna Chatterjee, extremely enthusiastic. She had the ICS award for the best ICS endorsed conference. She received the award for Swiss champion representing the team CNMC and H and ACP CON 2018 in Swabhumi, Calcutta. Received the third prize on quiz on the World TB Day in Kolkata. Again, a third prize for presentation of complicated cases of, we have one complicated discussion coming up, PPF. And she has 7 publications and research to her name and 1 book chapter on fever in ICU. With that, we start the panel discussion. Do we have everyone around? Do we have J.C. Suri around? I can't see him on the screen. Sir, Dr. J.C. Suri? Okay, fine. So, Nagarjuna, let me start with you itself. Like, the first thing when we decide or discuss about ILD is the name game. I call it a semantic name, a lexical puzzle. Why do we have so many names? And can you tell me the etymology? How did we ever come down and agree upon this final name? PPF to me means a very simple name. and finally means something? How do we ever come across to this?
So I think from what I have read, PPF is the latest proposed name. So earlier it was called as progressively fibrosing ILD. I think that is it. So fibrotic ILD is a different thing. So then came PFILD. So when PFILD came, so we started lumping all the fibrotic ILDs to one. And why was the name PFILD shifted to PPF? So progressively pulmonary fibrosis. Again, if you read the guideline statement by Dr. Raghu et al., they have said that it looks to sound somewhere similar to IPF, idiopathic pulmonary fibrosis. They have called it progressively pulmonary fibrosis. It's probably to make it easier for people to say IPF and PPF. That is probably one of the reasons which they have said. And
Basically, I believe that it was to target three things. One, target that it's progressive. Two, obviously it's in the lung. And three, that it's fibrosis. And not confuse it with all types of IIPs and ILDs. Just call it a simple name, fibrosis, such that it becomes even easy to communicate with the patients.
Yes.
So many times we use so many terminologies, USI, UIP, and a patient comes to me saying, I have an SIP. And I am wondering, where did he come to know about this NSIP? So I guess it makes sense scientifically and even communication wise. And patient communication becomes so easy with this PPF. And it tells everything what you have to know, even when you are communicating with the doctors or any other people. And therapeutically, it makes more sense. Welcome, Dr. Suri.
Yeah,
Can you hear me?
Yes, I can hear you. Whether you can hear me or not.
Oh, yes, sir. We can hear you very well.
Sorry for this confusion.
No problem at all. We're so happy to have you here.
Yeah.
So, Aparna, I wanted to put in a question to you. Now we have been talking about this PPF. Fine. We have now a kind of a disease entity of PPF. Can you tell us something about the global prevalence? Like, how common is this PPF by itself?
Actually, global prevalence varies in everywhere. Regarding if we see the ILD, the fibrotic ILD, non-fibrotic ILD, and I can mention regarding one study, that PERSEID study, which was done including large number of subjects including 6 European countries, and they have shown that the prevalence of the fibrotic ILD varies from 20 to 200 per lakh population, and every third of these fibrotic ILD cases, they present with the progressive fibrotic ILD. That means the prevalence is 7 to 70 per 1 lakh population. And in the Western countries, sir, the more prevalent is IPF and sarcoidosis among all the ILDs. And in our Asian countries, the hypersensitivity pneumonitis is the most predominant. But by far, the largest study, PERSEID study, it actually represents the document from the European countries, sir. In the India, that the PFILD document is not till now not available. I have searched, sir.
Okay, but we can actually extrapolate, like as with Dr. Nagarjuna's presentation, we have HP in one series as the most common ILD and sarcoid in another series as the most common ILD, and NSIP also with Dr. Dhuria's group. Yes. And half of them are progressive. So probably our Indian figures would be slightly more because we have a different variants of ILDs coming here in terms of the prevalence of ILD. Dr. Suri, welcome, and I would like to know the basic thing from you as to what is the percentage of non-IPF ILDs which show this progressive phenotype. And can you even tell us in your own clinical practice as to which are the most commonest pulmonary fibrosis which are progressing, more from your clinical perspective rather than what is there published in the books?
Yeah, thank you. At the outset, I would like to thank the organizers, Dr. Nene, for this opportunity. Now, coming to non-IPF fibrotic ILDs, I think the percentage of the total ILDs vary in different studies. It may vary in some studies, it is from 13 to 40%, and in other it is probably from 18 to 32%. So it varies, I think, from place to place, plus the diagnostic criteria which we are using, because the confirmation of the diagnosis may be a challenge in some situation. Particularly in our own country, when we see a patient in the late stages, then whether it is hypersensitivity pneumonitis or in some cases, end stage sarcoid, it may be difficult to differentiate. Though hypersensitivity pneumonitis, the history is quite characteristics. But if you ask me, in our clinical practice, we see, I think, hypersensitivity pneumonitis. I agree with Dr. Aparna. Is more common in our part of the world. And
so, but do you even see the progressive phenotype in HP only, or the progressive phenotype would be more common in the, say, NSIP? What is your clinical experience like? Do the HPs or the chronic HPs are the more progressive variants, or the NSIP, CTD NSIPs are the more progressive variants?
I think CTD NSIP would be more, Yeah. Yes.
So, do I take it from you as a kind of a message that when we see a progressive phenotype, we are either more often than not, we're probably seeing a chronic HP progressing and a CTD NSIP progressing rather than any other subtypes.
Yeah.
Sarcoid, we always see that more often than not, they do not progress as much. So a small subset does.
Yes. That I think probably would be the smallest category,
So Barney, we come to you with a very important question. Why the hell do we need to know about PPF? Why is it so clinically relevant? What really makes a big difference to these patients?
Thank you, sir, and Dr. Amita for inviting me. Really a joy to be here. A very pertinent question, sir. If we look at all our ILDs, we probably used to the thinking that IPF is a progressive one. The rest are not that progressive. That is there in our mindset for long. But now with this evolution of a subset of all of the IPF, non-IPF ILDs, we understand there is something that is progressing faster than the rest of it. And when we look at that, we have answers which are looking at two things. One is lung function trajectory, one which is looking at mortality or survival. There are a couple of large data, and we need to understand that this terminology came somewhere end of last decade. And after that, everyone is on antifibrotics. So the data are all from registries from early 2000 to 2015 kind of data where people have retrospectively applied these criteria. And what they found is two large 1,000 and 2,000 more patient groups found that progression is more, lung function decline is more in the PPF group compared to the non-PPF group. So that is very clear. The second message that comes very clearly is from mortality data. I think the two best studies to say that is the PROGRESS study from France published in ERJ and the Byung et al. Study from BMC. Both have looked at about 200 and 400 odd patients with PF-ILD and another 1:2 kind of, because of 30% distribution with non-PF PPF ILDs. And they found that after adjusting for all factors like age, lung function, HRCT pattern and all that, the diagnosis of PPF is an independent factor for mortality. And one study showed the hazard ratio of 2.5 and another showed a hazard ratio of 3. So when we label someone as PPF, they have 2.5 to 3 times higher chance of dying going forward compared to the group without PPF.
So, when this whole discussion of ILD, there was always an article published way back in 1990s that all ILDs are the same, that IPF represents one end of the spectrum and other ILDs represent the other end of the spectrum, and everything converges to a same type. And when we look at this mortality graphs, and when we see these PF ILDs or PPFs having a similar mortality curves as IPF, it really brings back to the same thing in mind. Are we all dealing with to a same disease with different ends of the spectrum coming in. And in the same regard, I come to you, Radhika, that when we are talking of fibrosis, I would like you to address two specific things. Nagarjuna has so beautifully and eloquently described in his text. He was very verbose about what constitutes fibrosis, what doesn't constitute fibrosis. I would like you to elaborate for the benefit of our listeners once and for all, what is fibrosis, what isn't fibrosis.
Thank you, sir. So Dr. Nagarjuna has made that very easy for me. So he very clearly mentioned that. So fibrosis on HRCT. So that's more of a radiological diagnosis of fibrosis, and characteristically that would involve three things. So the first thing that you would want to see is the presence of honeycombing, and again you would want to see that as layers of cysts, as we already know. They should not necessary that they need to be in more than one layer. So even one layer is good enough. They're generally subpleural. The next thing you would want to see is traction bronchiectasis. And the third thing you would also want to see is the presence of reticulation. So if you have any of these features, that would go in more of favor of fibrosis on your CT scan. Now, the other thing, what does not go in favor of fibrosis, I think we've got much more clarity in terms of what goes in favor of fibrosis. What does not go in favor of fibrosis? So again, so if you have, I think the most important is to identify an acute exacerbation of ILD versus something being a progressive pulmonary fibrosis. So if you have diffuse ground glass opacity is seen, that would go less in favor of fibrosis, versus some amount of ground glass that you may see near the traction bronchiectasis could represent progression of disease on CT scan. So I think more than what does not constitute, I think we have better definition for what constitutes fibrosis.
Yeah. This is one thing where we can rule in fibrosis rather than looking out factors for ruling out fibrosis is far more easier. And what Nagarjuna pointed out is a very important change, that even when you see a single line, a single layer of cyst, that by itself is recently constituted as a part of honeycombing. You don't need to see them stacking over each other to constitute honeycombing. So Nagarjuna, coming back to you, so what would be then the clinical criteria of progression? In fact, when you're looking for clinical criteria of progression, when Radhika said you have to differentiate from acute exacerbations, so clinically my patient is having more cough. Clinically my patient is having more shortness of breath. Is it all clinical progression, or is it something else which you need to always look for and rule out before telling that this is a clinical criteria of progression?
So I think this is a very important question. So we should always, whenever there is a clinical worsening, we should try to see whether it is attributed to the disease ILD progression or not. Because the same person may be having a concomitant cardiac disease, and the cardiac disease progresses, he might have worsening dyspnea. Similarly, he might have worsening pulmonary hypertension, and that can lead to worsening dyspnea. So I think this is something which you have to do on an individual level. You cannot give a broad consensus statement or anything, but we should keep it in mind that worsening dyspnea in a patient of ILD is not always because of ILD. It can be
the key. That's the key. It's not just one factor. Look for other things.
Other factors. That is first thing. Second, Dr. Radhika has rightly said, try to differentiate an acute exacerbation from a chronic progression. If the person comes saying my breathlessness suddenly worsened over 3 weeks or 2 weeks, then you are looking at an acute exacerbation. Vis-a-vis somebody who's telling my breathlessness slowly progressed over the last 1 year. I think this is something which is very important. But the only drawback for the current criteria is what worsening constitutes significant worsening. So that is something which is very subjective, and we don't have an answer as of now. So if my cough increased from this much to this much, it is more. So that is something which I feel is a gray zone in this. What grade of dyspnea? MMRC 1 to 2, 1 to 3, 2 to 3. What is considered a significant progression? We don't have an answer as of now.
Yeah. So there is a very interesting paper on that mortality when you compare what criteria of progression were used, whether you use clinical criteria, physiological criteria, or radiological criteria. And when they compared the Kaplan-Meier curves of mortality, they realized that if either of the criteria you use, all the mortality curves were overlapping to each other. So it's a very interesting thing that you may need not necessarily have all fancy lung function equipments with you, or you may have a very high resolution CT scan. If you are very clear about even symptom progression and can rule out other things which are causing, that by itself can be a very interesting criteria for progression and can predict mortality. So Radhika, then we have discussed radiological and we have discussed clinical. Can you tell me something about the physiological criteria? I was about to say that, but what he's already spoken about the physiological criteria in terms of absolute and relative decline and all that. Can you just make it more crisper, such that in few lines, such that it becomes very easy to take home apart?
You're muted.
Radhika, you're muted.
Oh, sorry. So again,
Yeah.
Dr. Nagarjuna has made that very simple for me. And he did spend a lot of time in his talk really explaining what the physiological criteria meant. So again, the most important thing we always need to see is that it's a combination of two of those three criteria. So you need to have clinical, radiological, clinical with radiological or physiological deterioration. And so just to make it simpler for us, what they've said is that in any absolute decline of FVC of more than 5% absolute prediction. So see if your FVC from 50% has dropped to 45%, we know that is significant. Or else, or even if there's been a 5% decline in the absolute value of FVC. So say suppose your FVC was 2 liters and that has gone down to 1,900 ml. So that has been a drop of 5%. Over a period of 1 year of follow-up. So now that is considered significant in terms of, along with clinical or radiological deterioration, to call it a progressive fibrosing ILD. The other criteria that they've used is DLCO. So any drop in your DLCO of more than 10% has also been used as a criteria for progressive fibrosis. Now, coming to the question, how often do we do this? So, Dr. Sujit Rajan's paper is very nice, said that possibly, doing these spirometric measurements every, say, 3 to 4 months is a good enough, time period to look for any drop in your FVC or look for progression of disease. And probably CT scans you would want to do once in a year or even less, even at a slightly higher duration, depending if they're stable enough. So, but I guess the majority of your decision in terms of whether progression would, I think, be based on clinical plus your repeated lung functions every few months.
So then, Barney, now you're next in queue to tell me that we already discussed clinical, we already discussed physiological criteria of progression. You need to tell me what is the radiological criterion of progression. With this, we complete the 3 major criterions which define progression.
Yeah, so when we look at the high resolution CT scan, there are 3 things that we need to look at. One is to look at the reticular abnormality, which indicates the interlobular fibrosis. Secondly, when there is fibrosis happening all around bronchioles and bronchi, they get stretched. That causes traction bronchiectasis or traction bronchiolectasis. Then we saw these cysts, which can be either stacks or single layered, which are honeycombing. Now, if any of these 3 are new or increasing, it would qualify as progressive pulmonary fibrosis criteria, radiological criteria. Now, we also need to remember that, I think Dr. Nagarjuna briefly mentioned that if there is an area where new ground glass opacities are there along with traction bronchiectasis, these ground glass opacities probably indicate microfibrosis that is seen along with traction bronchiectasis. So any of these, when seen in patients with non-IPF ILD. So that brings us to the question, how often do you need to do scans for non-IPF ILD that we are managing? So non-IPF ILD, there is no clear-cut...
I would rather, Barney, divide that question into 2. After your first diagnosis of fibrotic ILD, when would you do the CT scan? And then how frequently would you do it?
Yeah, so once you at diagnosis, we definitely need a CT scan. And after that, it will be based on the need, because you'll have to look at the clinical, the pattern, the symptom, the physiology, and then you decide. There is no hard and fast rule to repeat an imaging when we are following up patients, when you have good symptom resolution or stability and physiological resolution stability. But once you have progression and there is symptom and physiological progression, you need to do imaging for the confirmation of diagnosis of progressive pulmonary fibrosis. And once we do that, then things are slightly different, because this is already a progressing cohort. So at least every year there is some suggestion that we should do an imaging, and before that or later than that, based on how the clinical situation warrants.
Hypothetically speaking, and in general course of events, when you have a patient who has having an FILD, also have been documented to be having a PPF, there is no case, unless there is a worsening in between or something new happening in between, there is no case to do it earlier than a year. Do our listeners take this point home, that too frequent CT scans are not necessary. Less than a year is not needed. Is everybody on the same page with me on this? Okay, fine. So Aparna, I come to you now on the same question of relevance of PPF and mortality. Now, if we were to see the mortality between a progressive and a non-progressive pulmonary fibrosis, how do they differ? Can you get deep into it? How really different are the curves, and why this PPF becomes so important?
So from many studies, one recent study has been done in the Korea, and from some other studies, it has been seen that mortality in PF-ILD is always higher than the non-PF ILDs. That means progressive fibrosis ILDs, and there are some predictors of mortality also, sir. It has been seen in the various studies that PF-ILD itself is an independent risk factor for the mortality. Not only that, the older age, the lower DLCO, more FVC decline, these all are the risk factors for the mortality. And also we can give the reference of the IPF. Like in IPF, we can predict the patient by the pulmonary arterial hypertension, which is a risk factor for the mortality. So in case of PF-ILD also, we can follow up the patient by echocardiography, because it has been seen that systolic pulmonary artery pressure more than 36.5 millimeter Hg. In some studies, they have shown that it acts also an independent risk factor for the mortality in PF-ILD patients.
Brilliant. We must also be aware that it is not so easy to do a transthoracic echocardiography in progressive pulmonary fibrosis, and quite often the pH is underestimated. It's only on autopsies that you realize that it has a significant pH. We come to you, Dr. Suri, as now we already have discussed a great deal about PPF. How did the whole thing come into picture? How do we define prognosis? Why is the PPF by itself important about survival and things like that? Which are the patient profiles are more likely to progress? Which are the subtypes? We already discussed 2HP and NSIP. But what are the risk factors in these patients which really make them more vulnerable, or the preponderance of progression is higher? What are the risk factors of this patient? So you're mute. You need to unmute, sir.
Is it okay now?
Yeah, fine.
Actually, I have shifted to mobile phone. There was some power failure.
Not a problem.
Something is happening. So the risk factors can be linked with the type of underlying pathology or the type of the disease, as we discussed that patients, particularly those with the CTD, ILDs, those with hypersensitivity pneumonitis, they are at a higher risk of developing progressive disease. Then functional parameters, we can take those who have advanced disease, poor lung functions, and that's the another factor which you take. The radiological features also if you see advanced fibrosis, bronchiectasis, traction bronchiectasis, and honeycombing, and particularly loss of architecture. So these are risk factors, in these patients, which can lead to progression of this disease in these patients.
So we have now kind of discussed most of the things about clinical, radiological progression, survival. Now let's come to what really matters in the clinic across the desk, the therapeutics. And we all know that pharmacotherapy is something which excites both the doctors and the patients. They're really not very happy with these things. So, Aparna, first I would like to take you through the less preferred drug in the PFILDs or the PPFs, the pirfenidone. What is the current state of pirfenidone? What do the trials as of today talk about the role of pirfenidone in PPF?
So, sir, there are two important trials for pirfenidone in PPF. Those are, as told by Nagarjuna sir already during his speech, that UILD study and relief study. And in both the trials, they have shown that pirfenidone may have some benefit for the patients when used in the PPF. But, sir, so far the evidence is not that much strong as compared to the nintedanib. But they have shown there may be lesser chance of the decline of the FVC, DLCO, and symptomatic benefit may have for the patients, but sir, more larger randomized control trials are needed for the larger number of patients.
Especially in PPF, so one thing, another to really understand is if you are thinking of progressive pulmonary fibrosis, pirfenidone, as of today, doesn't really have a very strong ground to stand on. So, Radhika, we come to you about the other kid on the block, the nintedanib, the kind of the more pampered molecule for PPFs. What do you have to tell about that? And I also want you to tell me, do you have any inkling about, there have been a lot of questions on the chat box, a dual therapy, nintedanib and pirfenidone, both in PPFs?
So I think, the biggest data for the reason why nintedanib is preferred over pirfenidone is just because of better data. And this we all know from the inbuilt study that Dr. Nagarjuna referred to in his talk, which was a very eloquent study, done, included more than 600 patients with a fibrosing ILD, and that was defined over a period of 2 years in the criteria that we've spoken about. And patients are randomized to either receive nintedanib 150 twice a day versus placebo. And again, what they looked at was the FVC progression in terms of FVC decline in what was used, the same criteria that was used in the initial impulses studies for nintedanib and IPF. And again, what we found was similar data. So the ones who received nintedanib had their decline in FVC reduced by 80 ml as compared to the placebo group who had it to the tune of around 180 to 200 ml.
And that's almost the same as in impulses.
Exactly. It's almost the same in pulses. So in pulses was 80 versus 180. This was around 80 versus 200, depending on which group.
Yeah.
And this was seen across the spectrum. So in the inbuild, we had 1/4 of patients who had HP, 1/4 who had CTD ILDs, around 20% with idiopathic NSIP, and around 20% who had unclassifiable ILD. And across the board, whether it was HP or a connective tissue disease ILD, we did see an improvement, a lesser rate of decline of their FVC as compared to the placebo. And then, of course, we also had the census study specifically for systemic sclerosis, where they upfront gave nintedanib if there was some evidence of some ILD or fibrosis on the CT scan. And again, what they found was that there was a lesser rate and decline of FVC in the fibrotic group versus in the nintedanib group versus placebo. The tune was lesser, so it was 90 ml versus 50 ml. So that's why this study was taken with a pinch of salt, because it had no impact on clinical outcomes or the modified skin score that they used. Coming to the second part of the question, whether I have used antifibrotics, both of them, I haven't been so gutsy in terms of using both of them together. But I do know of a lot of colleagues in Bombay as well who have used both of them. I'm pretty scared of the side effect profile of nintedanib and pirfenidone and whether that would cause a double whammy. Plus, I'm not really aware of any scientific data of combination of the two therapies.
So that's why I brought up the impulses and the similarity of the impulses and the inbuilt with two different disease sets, IPF and non-IPF, and having similar improvement. And we've had dual therapy in IPFs. So taking just anecdotally and just putting the same thing over here, why shouldn't it give benefit, especially on PPFs which are worsening despite antifibrotics? So, Dr. J.C. Suri, like at your level with so much of years of experience, what is your take on dual therapy, on progressing fibrosis despite nintedanib and things not doing well, everything looking dark? What is your take on dual therapy in progressive pulmonary fibrosis, non-IPF progressive pulmonary fibrosis?
Yeah, I don't have any personal experience of using both the drugs together, but if we go by the pathophysiology and pathogenesis of IPF versus PPF, then it would seem to be similar. It seemed to be similar. So what works for IPF should ideally work for progressive pulmonary fibrosis also. So I think whenever one has to try a dual combination, then one has to look into the individual patient. Because both the drugs have common side effects in terms of gastrointestinal intolerance, in terms of liver dysfunction. So I think you may have to select your patient very carefully, and you have to see the response to the individual drug first, and then I think you have to, I think, select this patient very, very carefully before you go for this dual therapy. That's what I would say.
Why I'm asking so deeply about dual therapy is, with all due respects to all my colleagues here, with a kind of a heavy heart, so many times we see prescriptions of nintedanib and pirfenidone where probably the patient didn't deserve those drugs. I'm sure on review of those patients, the primary consultants might realize that themselves. Why I'm talking about dual therapy is, like, when something is in vogue, there is a lesser threshold of using things which are sounding new and sounding fancy. A word of caution needs to be told to every single person that in PPF, as of today, there is no place for dual therapy. Yes, trials are going on, but those trials are more in IPF and not in PPF. Maybe if we give some time, the trials will emerge where there might be a role for dual therapy in PPF, but let that time come. And that was a small word of caution for everyone who's probably slightly loose in prescription of the dual therapy.
No, we need to have I think, more data on this.
We need to have, of course, sir. There is no question. There's nothing moves without the hammer of science. So, Barney, in the meta-analysis of nintedanib, a lot of cautions were given as the limitations of the drug, especially the efficacy in subtypes of the PPFs. Can you elaborate on that? Despite when you looked at it as a whole group of PPF, there was significant improvement. But when you look at them as PPFs because of various subtypes of ILDs, there was a difference. Can we delve deep into that?
Yes, sir. Just one word on the previous question lingering on. I think it's important probably to consider what is quote unquote called switch therapy than dual therapy. So if someone is not tolerating or progressing on one of the antifibrotics, probably switching to another may be more tolerable and possibly effective, although not backed up by evidence as yet.
Sure.
And The meta-analysis on nintedanib comes by
one point, Barney.
Yes,
Though
sir.
it is not backed up by evidence, it isn't refuted by evidence because there is enough data on pirfenidone showing better effects than placebo, and nintedanib obviously is useful. So switching is not wrong.
Yeah, correct. I stand corrected and agree to your statement, sir.
Yeah.
Coming to the meta-analysis, now it's important to understand that there's a difference in the census inclusion criteria and the inbuilt inclusion criteria. Inbuilt is what we are calling PPF today, whereas the census was everyone with scleroderma with FILD. Now that's an important difference, and that's why in scleroderma it may have to be started early. But coming to the meta-analysis, so it was able to combine only the inbuilt and the post-hoc analysis of inbuilt done by Atul Wells et al. And those data or the subsets were combined together. And to understand that the overall benefit was something like 107 ml. But when they looked at UIP, it was about 128. Non-UIP was 75. Then when they looked at subgroup, the idiopathic fibrotic NSIP was 141, quite higher than the average and higher than even UIP. And fibrotic occupational lung disease was quite high at 252. Now, with these differences, there were three subgroups where he did not have any effect at all, meaning he did not have statistically significant increase. The confidence interval was going on either side of 0, and that was fibrotic HP, fibrotic sarcoid, and fibrotic unclassified ILD. So we need to keep that in mind. But having said that, there are a lot of trials that are registered from then on. A couple of Japanese studies in scleroderma ILD, the continuation study of the inbuilt trial data, and the InReal study, which is focusing on symptom resolution. But all of these are not completely published as yet. There are only, there is one study which has looked at the census studies. It's called Census On, where they took on certain patients with the census, in the census study about 250 and another DDI study. And they looked at 3 years data, and at 3 years, it continues to help in the decreasing the progression decline, and tolerability is acceptable at 3 years. But otherwise, there is paucity of data, I think, and in the coming year, there will be data that will be coming on the long-term efficacy and further data on the subgroups. Actually, the pirfenidone actually went on targeting subgroups. The pirfenidone in RAILD in various subgroups, that unfortunately, because of COVID, all those studies got stunted. And we don't have enough information on subgroups after the inbuilt meta-analysis.
Now, since you opened the door of COVID, I would like to put a question to Nagarjuna. Post-COVID, we saw a lot of fibrosis. How many times have you seen a post-COVID fibrosis being of a progressive phenotype?
So I think this has been debated in several forums. So by definition, not only COVID, sir, any bad viral infection will end up in some amount of fibrosis. But whether it would progress after the basic insult,
after the event, does it progress?
So usually it does not progress, with an exception of maybe a 0.1% of them where they had a persistent inflammatory storm. But I think that would constitute an extremely small subset. That is one. Second group of people where we had seen is where ILD was mistaken as the COVID per se. So that also happened. Any GGOs were taken as COVID.
Yes.
So was that the scenario also? See, if somebody is actually continues to progress. So nowadays also we see that they had COVID, residual infiltrate, now they're progressing.
Yes.
So whether it is true COVID which is progressing, the post-COVID ILD, but mostly it is not. So maybe they must be having an underlying ILD.
Correct.
When they developed COVID, which was picked up, and then that is progressing. That is something which we have to very clearly differentiate and understand.
We need to know this because, say, if it's a post-TB fibrosis, it's a far more easier radiological differentiation to say that it's a post-TB fibrosis than it's a post-COVID fibrosis. So while we are going through of ruling out or various subtypes of ILD, it is important to keep it in mind whether it is post-COVID fibrosis, because that's generally just not a progressive phenotype. And even those patients have come across where there have been unfortunate instances of they having been on antifibrotics. Nagarjuna, even just an additional line on pirfenidone, since we have more than a decade, I would say 15 years, or I really don't know when pirfenidone came into, I don't remember now. But it's been such a long time that we have been working on pirfenidone with our country, especially ours. Any other meta-analysis which has been done in the progressive phenotype which is showing any favorable results apart from the only two which we have been talking about?
So I think I could come across only one meta-analysis which I had shown in the talk, and that also had included only two studies. The UILD study and the relief
Nothing
study.
else is.
In fact, as Dr. Barney has also said, the other studies which have been there in the register have not been published yet. So there are a lot of individual studies on pirfenidone in this, that which have been officially registered that they are recruiting. None of them we have the official results yet. So talking about pirfenidone, the individual studies did not meet the primary endpoint.
Okay.
But when they clubbed the two and tried to look at it, it somehow fulfilled the p-values had actually become significant. And the FEC difference was again 100 ml, almost very similar to what was there in nintedanib. So probably if the relief trial would have recruited the number of patients it had intended to recruit, maybe it would have shown some difference, because it was prematurely halted because of delay in recruitment. That was what has been proposed. So, but what I would say is that just because that two studies did not meet the criteria,
doesn't mean
you should not go home with the message that nintedanib is definitely superior to pirfenidone.
Yeah,
it is that we don't have enough data
on that.
Yes,
especially because pirfenidone in past decade, I have hardly come across patients who are on ILD who have now become steroid faces or what we used to see in early 2000s. And all these patients have been only on pirfenidone, and going by the current data, most of these patients probably had PPFs and which are non-IPF PPFs, and yet they're doing well. So retrospectively speaking, probably if somebody were to pick up all these patients and do their study and read their CTs in the past 10 years and find out what treatment they were taking, maybe we can come out with something. We all should get together and do that. And looking at the number of patients, 200 patients will give us a good answer. So, Radhika, everybody wants to start antifibrotics. I want you to categorically tell me when not to start antifibrotics.
Okay, so I think simpler is to answer when to start antifibrotics. So, of course, we know.
You always say the opposite side first.
Okay, so I'm going to answer your questions. So, when not to start antifibrotics. So, I think you have to have, as the definition says, right? You have to have evidence of progression. So, it has to be a progressive pulmonary fibrosis. If you're not seeing evidence of progression, then there is no point starting antifibrotics. We all know the definition of progression, so we've discussed it in the lecture. We've discussed it in the panel discussion. So only when you've clinically and radiologically or clinically and physiologically demonstrated that there has been progression despite optimum therapy. Now, what do I mean by optimum therapy? If your patient has a CTD-ILD, they have to be on appropriate immunosuppression, whether that's with steroids, whether that's with MMF, whether that's on methotrexate, depending on what the underlying CTD-ILD is. If they've got another phenotype of a PPF, so if they've got HP or if they've got, so they have to be on the appropriate treatment first for that. And despite that, if they progress, then you would start with antifibrotics. But just because you've seen fibrosis on the HRCT or you've seen a bit of honeycombing on the HRCT should not be a reason for you to start antifibrotics. So you would possibly want to.
How long would you wait? How long would you wait before labeling? This has already been through into the lecture. How long would you wait before labeling this person progressive?
So again, the criteria said 1 year, but anywhere between 6 to 12 months is what you would want to wait before seeing evidence of progression.
Okay. So this is one big message I want every one of the listeners to take home, that there are criteria to start, as Radhika said. Nagarjuna said that in his lecture as well. And there are criteria where it just doesn't benefit. It is just not warranted. So please hold on your horses when you see a fibrosis. Don't start salivating and prescribe. It doesn't always work. Dr. Suri, you've done immense amount of work in sleep. I want to have a slightly tangential discussion on progressive pulmonary or just pulmonary fibrosis, on the prevalence, the incidence, and the outcome of the patients having comorbid sleep apneas in patients with pulmonary fibrosis, and how does it change the outcome?
See, interstitial lung disease is now considered a risk factor for obstructive sleep apnea and sleep disordered breathing, because we know lung volumes are an important risk factor for developing OSA. So once you have any kind of restrictive lung disease, which includes DPLDs in general, so that may result into development of OSA or maybe sleep-linked hypoventilation. Now, this is associated with the superimposed significant pulmonary artery hypertension. And I think this pulmonary artery hypertension can accelerate the progression of the disease. So that way, it may cause worsening of prognosis in most of these cases. And the major factor would be, I think, on pulmonary artery hypertension. That is what we have seen, and that can lead to right heart failure and progression. So that's why when we are talking about PPF and we are talking of progression, you have to look into other comorbidities, like Dr. Nagarjuna was mentioning about congestive heart failure. So because if you are looking into clinical criteria, it will definitely lead to worsening of dyspnea. There may be cough, and this may also have an impact on lung functions, because the vital capacity may fall, the DLCO may change because of the lung congestion. So it may also change CT picture, because if you look into the CT scans, the GGOs, the ground glass and picture, may, because this one picture is something which can be due to fibrosis, and this can also be due to pulmonary edema. So when we are looking into these things, the pulmonary artery hypertension, these patients are also associated with the diastolic dysfunction. There may be remodeling of the left ventricle. They also develop pulmonary edema. So I think the whole picture becomes quite complicated and confused. So whenever we are evaluating these patients for progression, we should look into other factors.
Sleep apnea and appropriate treatment for that.
Yeah. So superimposed sleep apnea is a very common complication in patients with ILDs. So has to be definitely, it's a very important comorbidity. And there are, I think, some studies at present. I may not be able to give you the names this thing, but treatment of sleep apnea in these patients is associated with better outcome.
Yeah, it's a study coming out from Dr. Nathan in Virginia, which says treatment of all the comorbidities will have an overall improved outcome in this thing, which includes sleep apnea. And the second question goes to then Dr. Nagarjuna as to treatment of comorbid pulmonary hypertension. The ACS came out with guidelines in 2022, but it just spoke of pulmonary hypertension in ILD. I am now interested. What is now the state of using anti-PH drugs? Of course, the drug which is recommended is still not very easily available here in progressive pulmonary hypertension, progressive pulmonary fibrosis, because there the prognosis is going to change completely.
Yeah, one thing more I would like to mention here.
Yes, sir.
Before we go into the treatment of pulmonary artery hypertension is the frequent presence of GERD, gastroesophageal reflux in patients who have comorbid obstructive sleep apnea. And that is also known to be one of the risk factor for progression of IPF. So I
Yes.
think that also has to be taken into account.
Yes. In fact, in one of the studies, it showed that the average survival of patients taking reflux medicine was 1500 days, vis-a-vis
Yeah.
700 days for those people who are not taking. But again, that was a study for ILD. But we really don't have an idea, because right now the ATS guidelines are not 100% in favor of treating GER. It's an equivocal recommendation. We are not too sure what if this patient has a progressive pulmonary fibrosis. Nagarjuna,
Yeah.
I want you to tell me about pulmonary hypertension. Your patient now has a documented PPF and he has PH. Could be to the severity of just 40 or 50 PASP, or a pulmonary acceleration time of just about 21. What would you do?
Sir, I think it's a very tricky question to answer, but I think the general consensus is if we feel that the pulmonary hypertension is proportionate to the severity of ILD, in general, you would not want to add a specific anti-PAH therapy. Vis-a-vis, if you have a disproportionate pulmonary hypertension, that phenotype wherein the ILD is not significant enough to explain the amount of pressures you are seeing, then you would want to do an RHC, confirm, and then put on anti-PH therapy. This is what I would say. More
How many
so.
RHCs have you done for PH in ILDs?
Huh? This
How
is
many
just to, so RHCs in our center, we have started doing RHCs for unexplained disproportionate pH, basically to look at the PCWPs, to look at
Yes.
this diastolic dysfunction of the
Yes.
left heart. So if that is not elevated, then it would indicate a precapillary thing. And
Any words on using treprostinil in?
So I didn't hear the question.
Any thoughts on using treprostinil in the prostaglandin inhibitors, treprostinil in PH in ILDs? Proportionate, not talking of disproportionate. The
So no
ECS
experience.
2022
So no experience.
did
I
a
would say.
conditional recommendation.
Very frankly speaking, no experience. So I should not comment, sir.
No, we don't have it in our country.
So that was the reason I had said that no experience. So I cannot answer that particular question. Then Dr. Barney can give a comment. Yes.
Yeah,
Yes, Barney.
thank you.
Please
No,
go
no,
ahead.
just that.
Yeah,
I mean, I
please.
know we don't have it in our country, but there is a NEJM randomized control trial which showed that inhaled treprostinil has
Yes, that's the
significant
only
benefit
trial
in
which
walk
showed
test.
benefit.
Yeah. So maybe there are now trials going on in UK with more inhaled therapy in PH-ILD, because the inhalers are likely to reach the ventilated parts of the lung and not the fibrous parts, and they will proportionately vasodilate rather than disproportionate vasodilation with systemic vasodilators. So I think in the future there may be a role for inhaled drugs in PH-ILD.
I think Dr. Barney has got the correct thing. So the reason why we do not give blanket pH therapy in group 3 is for this particular reason. And that is what the inhaled drugs actually target.
Hope we can get it soon, because there are many patients who are not really doing well. Archana, now I also want you to touch upon the incidence and prevalence, or just presence or absence of obstructive airway diseases in interstitial lung disease. You have any data, anything on that, which can also improve the outcomes in interstitial lung diseases, especially the progressive variants?
So, sir, regarding this, I would like to mention regarding one study that was done in Belgium, and it was a 17 years long study. They observed 557 patients, and they have shown in the study that 35% of their study subjects developed progressive fibrosis ILD, and 15 to 16% developed obstructive ILD, which they have mentioned as bad phenotype. OILD bad phenotype, because sir, in these patients it has been seen the survival is also lesser. That is, it is a predictor of the or risk factor for the mortality. And also, sir, one thing I must mention that we know sarcoidosis makes one subtype of the progressive fibrosis ILD variety or PPF variety. Sarcoidosis has a tendency to develop obstructive airway disease. Also, in case of RA-ILD, which is very prevalent in our country also, smoking acts as a risk factor, mostly for 25 or 30 pack years. And sir, these patients major number of the patients have tendency to develop obliterative and obstructive and follicular bronchiolitis. So they may also present as COPD or asthma-like features, obstructive disease variety. So, sir, these patients we should think about for the better management with the LABA-LAMA ICS or any other ways, and also by the pulmonary rehabilitation, because they have more chance of the mortality compared to non-obstructive airway disease phenotype.
Yeah, what we need to remember is that when you're looking at the interstitium, don't forget the neighbor airway, because there
Yes.
could be an involvement there, and again therapeutically this thing. Finally, Barney, I want you to answer one important question. Once you have instituted, is this kind of phenomena of progression a never-ending one? Once you have instituted an antifibrotic, would you ever think of stopping it? Does it ever stop progressing?
Yeah, one small deviation with your permission on pirfenidone in ILD. So there are some preliminary data coming from the scleroderma lung study, which is comparing pirfenidone MMF and pirfenidone placebo upfront. Preliminary data suggests that, interestingly, at 6 months, there is a increase in the lung function, not decline, increase in the lung function in the combination group. But we don't know whether it will be sustained. We are awaiting the results. Just wanted to make a point that there is some hope for pirfenidone as well.
To me, that is the more complete discussion. I have a huge number of questions. I'm sure the organizers will allow us to go for another 10-15 minutes.
Sorry, I have not addressed the question, the last question, sir, which is very important.
First, when did you ever stop it?
Yeah. So, I mean, I think that's a very challenging question, and
that's why I asked you.
The easy answer or the straight answer is no, because once you started, and even if the disease stabilizes, there was a progressive phenotype which is likely to re-erupt once you stop the antifibrotic. So it's a tricky question. Unless it's proven by randomized controlled trials of stopping and non-progression, we cannot go by it. On the other hand, we have data from extension of the larger trials in nintedanib and the pirfenidone trials, where in those who were on the placebo group, when they were added on after the extension arm, they were given antifibrotic, their rate also declined. And in those who stopped the drug after the trial was over, there was a progressive decline. So these indicate that probably once started, it is a drug that we have to give for life. And that is why it's so important to make the decision of the identification and the need before we start, because it is about 5,000 rupees a month for the rest of their lives.
Money apart, at the end of the day, you have to be stuck with the medicine for a long time. Yes, sir. Please, sir.
Is there any data that continuing with these antifibrotic is associated with the decrease in the incidence of acute exacerbation?
Yes. Both nintedanib and pirfenidone not only reduced the in fact, there were various surrogates. It reduced the decline in the FVC. It reduced the frequency of exacerbation. It also increased the time to first exacerbation.
So that is a very important reason to continue.
Yes, sir. Only thing is that this was not seen in the we really don't have the subsets of PPFs where subjected prospectively to see whether they are going to have lesser exacerbations. So how do you address Dr. Bhavyaja Nadu Vilpat Vishram from Maharashtra? How do you address pulmonary hypertension in patients with PPF? We have already addressed that. Unless we have a disproportionate pH to the extent of ILD, at this time the treatment is not warranted. Am I right, Nagarjuna? That's the position statement as of now, right?
I think what is the role of here? A role of oxygen is very important. So, oxygen.
Yes, sir. Please go ahead. I would like you to tell me the use of role of oxygen in progressive pulmonary fibrosis. How do you start? How do you continue? And what are the criteria?
So we don't have clear-cut guidelines for that, but we can follow the same guideline as we have for the COPD. But once we have significant pulmonary artery hypertension, then I think oxygen may be one modality which can significantly reduce pulmonary artery hypertension. One should give it. Now, the only question is whether we should give it only during physical activity, during sleep, or during all the 24-hour period. So that clear-cut guidelines are not there.
If I'm not mistaken, Radhika or Barney, you can come in here as we have guidelines or data on improvement in survival in COPD. We don't have that survival data in ILDs by oxygen. It only improves the quality of life, but does not add to any years to life. Am I right, guys?
Yes, sir, you're right.
Symptoms.
Yeah. So as of now, sir, like the NOTT trials we had, you give 14, 16 hours. It doesn't work for PPFs. At best, they give it during exercise, tolerating a saturation till dipping till 90 or 88. Anything less than that, you please take it till you feel comfortable. And nocturnal oxygen only if you have significant desaturations in night documented by a nocturnal oximetry. So we have Harvil Soni from Gujarat, a patient of HRCT suggestive of UIP NSIP pattern, or UIP or NSIP. What should be done next? Nagarjuna, your favorite. What should be done next to confirm diagnosis? Patient not willing for biopsy. Oh my God.
So I think this is going out of the topic, but what I would say is thorough history, focusing on the exposures, occupation, drugs, so on and so forth, and an extensive profiling.
I think MDT will answer all the questions.
MDT based on clinical and radiological criteria. You will have a lot of clues from these things, and that is how I think you won't have a single straightforward answer.
Yeah, true.
So that is
Dr. Sawant from Maharashtra wants to know what are the current diagnostic criteria of PPF. I think we have dealt with that in great detail.
So yes, one point I would like to add, in the pulmonary hypertension out of proportion to the ILD, I think it's important to also look at alternate etiology. For example, ILD can be a risk factor for pulmonary embolism. In a middle-aged female, we have to search for CTD, even though initially we would have done the workup, it would have been a forme fruste ILD, but now CTD features may evolve, something to keep in mind.
Very true, very true, very true. Dr. Rida wants to know about the role of pulmonary rehab for patients with PPF. I guess it's well established that pulmonary rehab, not only for COPDs, but for ILDs has a great impact. Dr. Sanket, how do you approach palliative care in patients with advanced progressive pulmonary fibrosis? This is what Dr. Suri was talking about, the role of oxygen.
So I want to add a point that palliative care in ILD starts very early. Sometimes we think of palliative care as when they are requiring oxygen, moribund on the bed. Palliative care inputs are required very early on, and that really helps in the overall quality of life. So there is a nice graph which says as the progression goes on, palliative care input starts come. So PPF, I think palliative care should be taught earlier. Like for example, breathlessness, handheld fan, so many small things can change the quality of life of the patient.
So I
yes,
think,
Radhika.
I just want to add one more point here. So I think once you've established a rapport with your patient, I think even talks of how they see their disease in terms of would they ever want to be on a ventilator, would they ever want to go to hospital, advanced care planning, those are topics that should also be touched upon with your patient. Of course, not at the first visit, but once you think you've developed some sort of a rapport and once you think the patient kind of has a grasp of their illness, because a lot of these patients do not want to be on the ventilator, but they'll end up in an exacerbation, and if that's never been discussed with them, majority of our patients de novo by default end up on the ventilator. So having those discussions prematurely at a time when they are cognitively intact, at a time when they can take decisions, I think should also be a part of your palliative treatment.
In fact, once you see the progressive phenotype, you should also start the conversation around transplant. Just start the conversation because that's the direction it's going to go in for. Am I audible? Is this I can see the screen froze.
Yes, sir. We are. No. You're audible, but you're froze. Now you're not audible, sir.
Okay, so what I will do is I will try to log in from the cell phone. What are
can
the
hear
most
you.
effective
You are audible.
strategies?
You are audible now.
Achha, I'm audible. Fantastic.
Yes,
sir.
yes.
Yes,
So,
sir.
what are
Yes.
the most effective strategies for slowing down the disease progression? Anyone? Nagarjuna?
So I think there are a lot of questions on the similar basis. So because we have only spoken on the role of antifibrotics in PPF, but when you diagnose somebody as a PPF, it does not mean we would completely stop the background immunosuppressive medicines. So I think it's a combination of the immunosuppression for the underlying etiological ILD plus addition of the antifibrotic as deemed necessary. And that would be the best combination to slow the disease progression in non-IPF PPFs. So I think that is what I would say. So before Dr. Kumar sir logs in, I think any comments from Dr. Barney or Dr. Suri sir?
Yeah, I think it's very important that these patients should continue with the specific therapy along with antifibrotic. Because as seen in the census trial also, there was a subgroup, so where they have given a combination of nintedanib and mycophenolate mofetil. And this group had a much greater fall, reduction in the reduction of lung function fall. It was almost, I think, uh, in the double. I think in the first group it was 52 ml, and probably this combination adds something around 25, 26 ml. So there is a significant difference. So the combination therapy is quite important in such groups.
I have one question from West Bengal. I am not able to read it. Yes, a middle-aged woman, negative seromarkers for CTD, HP ruled out, severe hypoxia, any role of antifibrotics. Just has fibrotic ILD, negative markers for connective tissue disease, hypersensitivity pneumonitis ruled out, patients having severe hypoxia. Now, this is the most common situation which we all face. Like, this is a point presentation coming to us with severe hypoxia. So the question is, any role of antifibrotics? I'm sure they have tried enough steroids, but now this is what people want to know. Would this be the point to start antifibrotics?
I think if you've demonstrated progression on her.
So this is the first time this patient has come to them for the first time.
So, I mean, if there are no previous CTs or any previous lung functions, so you don't have a snapshot of, I mean, this is a snapshot. You have no idea in terms of what's been happening over the past.
Yes.
Or she actually presented. So I would probably not start upfront antifibrotics here, especially if I don't have any evidence of even like a connective tissue disease here. And I would treat her with immunosuppression and say after a few months, say, probably have a low threshold, repeat a lung function in say 4 months or so, or even a CT. And if I do see progression at that stage, I would add antifibrotics. It'd be interesting to hear the other panelists.
Yeah, would love to.
Yeah, actually, this may be one of the risk factors for progression. If we say if the initial lung functions are very low, that could be one of the risk factors. Secondly, in most of the trials which have, the patients have which have been recruited are of mild to moderate category. We have very few patients in very severe category where definite benefit has been shown with these antifibrotic drugs.
I think
So I don't know exactly.
So am I to our Dr. Suri, you're trying to say that this patient probably has a very severe disease to begin with, and antifibrotics are unlikely to benefit, so no point starting, give them a good amount of steroids, then at least tide over the crisis before jumping onto the antifibrotic bandwagon. Am I reading you right?
Yeah, we don't know much about such group of patients. That's what I want to say, because the patients which are recruited in most of these trials are of mild to moderate severity. They very few patients in this category of severity included these trials to have shown significant benefit. So we don't know much about it in such a category of patients.
Any thoughts, Nagarjuna, on such cases coming to you in the OPD?
So that is the sad reality of India, that we do see people like that they are coming for the first time. But only thing is that had they been on optimal therapy before they came to us, so that is the most important thing, is you take a good history. So if they were already on therapy and progressed to such a state, then probably you may be justified. But if a person is severely hypoxic, I would talk more of transplant than antifibrotics. In a middle-aged lady, I think that is what I would be more interested in rather than antifibrotics, because I think it would be too late if a person is severely hypoxic and then try to expect a miracle to happen. But whatever said and done, that question has too little information for us to really give a therapeutic decision. We need more information actually.
So there is another question coming in from Maharashtra. Very interesting question, that this patient is on immunomodulators. The patient is on 2 grams of mycophenolate. Dr. Chatterjee has asked this. Dr. Trijip Chatterjee. Oh, I was sure sir is going to ask an interesting one. So a patient with chronic HP with a good amount of immunomodulators like MMF, evidence of PPF, would you start antifibrotics and stop the immunosuppressants and just give monotherapy, or give both?
So this was what I had actually said in the one of the slides. So when you diagnose PPF, you are justified in starting antifibrotics, but what would you do based on immunosuppression? Would you hike the immunosuppression also? Would you continue the same, or would you withdraw immunosuppression because the disease has progressed despite immunosuppression? So I think this is something where we do not have a very strong guideline consensus, but I would not stop, because other than IPF, in most of the other non-IPF ILDs, it is inflammation which leads to fibrosis rather than the direct fibrosis which happens in IPF. So I think we should not stop the background immunosuppression while starting antifibrotic.
Nagarjuna, you need to know, we can't be diplomatic here. We have to put down our foot and say we should not. The reason being very
no, that's what I said, sir. We should not.
We should not, definitely not, because it is just not that the inflammation is switched off and the fibrotics has started. The inflammation is continuous, and the more anti-immunomodulators you give, probably you will retard the progression of those inflammatory sites to the antifibrotics. So as Nagarjuna said, we continue both. Now, there is an interesting observation from Dr. Suresh from Tamil Nadu, that when we are looking at the absolute decline in the physiological functions, we should at least ensure that the prediction equations which have been used in the various tests are the same and not different. An interesting observation, otherwise we are going to make the whole mess of our thing. Very nice point, Dr. Suresh. Dr. Ajil Anjevar, are all faculty seeing post-COVID fibrosis very much as expected and predicted? I guess so, yes. My answer is yes. What about the rest of us?
Yes, sir. We see a lot of post-COVID residual fibrosis. That is definitely there. So whenever we see a person of ILD sort of picture on CT, we should definitely take history of previous severe COVID infection, if at all they have had.
Yeah, Dr. Sujata has also asked a question, that would pirfenidone help in post-TB fibrosis? No evidence, no data, hypothetically also very unlikely to help. And obviously the answer, which I'm sure most of my faculty would also say, a very simple no to that question. But maybe time to come with, who knows, as of now, no. Dr. Shinde Latur, he's congratulating you all on a fantastic panel. I was just reading that, sorry about that. Dr. Balbir from Punjab, Amritsar, a role of steroids and other immunosuppressants in PPF. We already said it's P and F, so we're talking of antifibrotics, steroids, and immunosuppressants only for the inflammatory component, which continues to be there. We discussed this in the previous question. Okay, the disease by IPF is a fibrotic malignancy. A nice take on that. Hence TKIs work. But in CTD ILDs, the fibrosis is preceded by inflammation. So it is more of a healing fibrosis. The body has to heal. What we need to target is inflammation. PPF in this context is, this is a rant actually. The PPF in this context is more of a pharma gimmick. Anyone from the panel can share his experience whether we can halt the progression after starting antifibrotics. With all due respect, sir, we cannot halt the progression by anything. We can retard the progression. The amount with which we can retard the progression is also there in all the trials. It would be too harsh to label it as a pharma gimmick. We have actually seen patients getting better. The smallest evidence I can give is in our own clinical practice in past decade and more than that we have stopped seeing those steroid phases and steroid dependence in ILDs, which we used to see in the 90s and the 2000s. So, a very polite disagreement with your view, sir. Dr. Gandhi from Odisha, whether significant difference in FVC as far as studies is clinically meaningful. Interesting question. Significant difference in FVC, is it clinically meaningful? You might see an FVC of 1.6 liters and on follow-up you might see an FVC of 1.3 liters, which is more than 5% of absolute decline and more than 5% of relative decline. How often have you seen that the patient continues to be clinically the same? He is not changed. His dyspnea has not worsened, cough not worsened, but you see the FVC decline. Barney, Nagarjuna, Dr. Suri, any thoughts on this? We see a physiological decline, but not a clinical decline in patients. Is this FVC always clinically meaningful?
So I think one thing is the way the PFT was done, was it an appropriate maneuver or not, is something which we have to be very, very clear. So if it has been properly performed, then I think we should take cognizance of the fact that it has fallen down.
Okay, so we take the parting words from all our panelists. We'll start from the speaker, Dr. Nagarjuna from Yashoda Hospitals. Thank you very much for being here. Parting shots, Nagarjuna.
Sir, the only thing I wanted to reiterate is that all fibrotic ILDs do not progress once we give the correct therapy. So just when you see fibrosis on a CT, do not jump to give antifibrotics.
Okay. We start from the junior most. Aparna, parting thoughts?
You're on mute.
Aparna, mute.
So, sir, I would just like to mention one thing, that whenever we are diagnosing any case of ILD, we should think about the proper diagnosis, as Nagarjuna sir has already said, because without proper diagnosis, we cannot proceed further, and that will guide us for the future follow-up of the patient.
Radhika, any thought that you can sleep on tonight?
I think before jumping on to starting antifibrotics for PPF, make sure you optimize your underlying therapy first. And only if you have the correct evidence of progression, please start antifibrotics. Don't just jump to start antifibrotics if you just see a UIP pattern on your CT scan.
Hold your horses back. That's what Radhika is saying. Barney.
Well, I would say always start clinical. Look at the clinical picture, then look at the physiological picture, then radiological picture, and put it all together and pick up PPF as early as possible for best outcomes.
So don't chase the investigations, chase the patients.
Yeah.
Dr. Suri, sir, last thoughts? Are you around or sir is left? Oh, I guess sir is left. Okay, so it's 10:30. It was an extremely interesting discussion. A wonderful lecture by Nagarjuna, clarified everything. I dissected it further and told the same thing again in the next 1 hour. It was a very, very beautiful discussion with you all. Nice meeting you. maybe we should all catch up someday, not discuss respiratory medicine. And thank you, Sipla, especially for being such a generous, gracious academic partner since such a long time for ICS. Thank you, Dr. Salvi, Dr. Dhar, and Dr. Amita Nene for giving us an opportunity to get together on a Wednesday night to discuss PPF. Thank you so much. Thank you all. Good night.
Thank you, sir.